Hi, my name's Ed Johnson. Today we are going to learn about mania as it relates to bipolar disorder. I know there's also a depression component to bipolar disorder that that's already been covered in the class that I'm in with Antioch University. I'm a student at Antioch University, and this presentation is for my class. So let's get started. Mania, manic episodes related to bipolar disorder. Um, we're not talking about uh, mania caused by schizophrenia or pyromania or anything like that. This is the mania we're going to cover. It's also it's called manic episodes. Manic depression is a frustrating mess. Uh, that was written by the great psychologist Jimi Hendrix. Actually, Jimi Hendrix played guitar and sang, but he did a song called Manic Depression. And I don't know if Jimi Hendrix had manic depression, but I wouldn't be shocked because there's been a lot of famous, talented people in history who've had manic depression. Um, I'm sure you've all heard the song Manic Depression Touching My Soul. Okay, let's go to the next slide. This is the part of the history of bipolar disorder. According to my research, it's probably been around as long as man has. The ancient Greeks, they wrote about behavior of individuals that kind of seem to indicate bipolar disorder. We can't really know for sure because we don't have a time machine and we can't go there. But it was probably bipolar disorder. The German psychologist Emil Kraepelin first coined the term manic depression in the early 20th century. And in 1980, the term was changed to bipolar disorder. Um, here's just a few of the historical people that is believed to have had bipolar disorder. The talented composer Ludwig van Beethoven, one of my favorite people from history, Winston Churchill. He called his depression associated with bipolar disorder his old black dog. Like he had an old black dog that sometimes it would run off and stay gone for a while, but it would always come back. Edgar Allan Poe, Virginia Woolf, the Rough Rider American president Teddy Roosevelt, and famous boxer Frank Bruno. They were all believed to have had bipolar disorder. This is Emil Kraepelin. He's the one that first coined the term manic depression in the early 20th century. I don't have the exact date. I couldn't find it. But he died in 1929. So you got to figure it had to have been pretty early. Um, it's believed that 3.5% of the U.S. population they have bipolar disorder, and that translates to about 5.7 million people in the U.S. and over 14 million people worldwide have this disorder. People who have bipolar disorder are 60 times more likely to commit suicide. That's a statistic I got from the video. It's listed here. The DSM-5 puts that number more at like 15%. So I'm going to go with that. But that's quite a bit. and it's sad. Okay, there's two different types of bipolar disorder. Symptoms are pretty much the same. Just with bipolar one disorder, you have to have the symptoms for at least a week, most of the day, every day, for a straight week. And with bipolar two, you just have to have them for 4 days, according to the DSM-5. It's a period of abnormally and persistently elevated, expansive, or irritable mood, and abnormally and persistent increased activity or energy. That's if you're just up, you're doing that, you're doing five things at once. Somebody says something to you, it gets on your nerves, you're irritable. And type one, it's got to last for 7 days. Type two, 4 days. All right, here's some of the symptoms of bipolar disorder. You'll have an inflated self-esteem or a grandiosity, a decreased need for sleep. You're more talkative than usual. You have a flight of ideas. It's like, you know, all kinds of ideas running through your head. You're easily distracted. You have a huge increase in goal-directed activity. And people with bipolar disorder often engage in risky behavior. And I'm going to go over these one by one. Inflated self-esteem or grandiosity. Uh, the client may embark on a complex task with no experience, just trying out for a professional sports team or writing a novel. Um, I knew a guy that had just started golfing, and he said he was going to be a professional golfer, and he thought it was going to happen within that year. And I mean, you might think, well, you know, good for him, but he really had no experience and no knowledge on how to get there from here. So that would fall under inflated self-esteem. You may have a delusion about having a special relationship with a celebrity. Um, I know a few years ago, there was a woman that believed she was married to David Letterman. She kept breaking into his house. Uh, Something like that would fall under this. Although I don't know if she had bipolar disorder, she may have. Um, and part of this is the client will ignore evidence contrary to their beliefs. Like I would have told my buddy, I said, hey, you just started golfing last month. Why do you think you're going to be a professional? Those guys have golfed since they were little kids. He would just ignore that. Or if you tell the woman that kept breaking into David Letterman's house, said she was his wife, well, there's no evidence on the internet of you being married to David Letterman. David Letterman's filing charges against you. Uh, that evidence would just likely just bounce off of her, and she would ignore it. Let's go on to the next one. The decreased need for sleep. Now, don't confuse this with insomnia. Insomnia is when you want to fall asleep and you just can't do it because your mind's racing. This is more of a thing like you don't feel that you need to sleep and you feel totally energized. You can stay up too late get up at the usual time, or you can wake up several hours early, feel refreshed and full of energy. In severe cases, a client may go without sleep for several days and not even feel tired. Um, some of us might think that would be a cool thing, but there's chemical changes that happen in the brain when you go without sleep. And so this is definitely not a good thing. People with bipolar disorder, they're more talkative than they usually are. Speech may be rapid, loud, and difficult to interrupt. Um, they may talk continuously and not have any regard for others' need to communicate. Like say they just keep talking and talking, and then you try to break in to ask a question or make a point, and they just keep on talking. It's kind of like those telemarketers that call your house. They don't give you a chance to say, no, I'm not interested. If the client is irritable, the speech can be marked by complaints, hostile comments, and angry tirades. So that's definitely not good. Um, People with bipolar disorder, they have a flight of ideas. The thoughts in their head will race faster than what they can speak them. They've just got so much going on in here, but they can't get all the ideas out at once. And that's part of the reason why their speech is really quick. Um, they can have abrupt switches from one topic to another. And speech may become disorganized and just really incoherent. Distractibility, inability to censor unimportant stimuli such as room furnishings or therapist's attire, what the therapist is wearing. Um, I know a person that was doing bad in school. They were a little mentally ill, but they said the buzz of the overhead light was distracting them, and they couldn't concentrate on anything because the light buzzing was just driving them crazy. Um, you know, the distractibility may prevent the client from having a rational conversation, or it may prevent them from following simple instructions. So it is hard to talk to a person who's in the middle of a manic episode. There's an increase in goal directive activity. There's excessive planning, multitasking, and they may have an increased sex drive and increased sexual fantasies. Uh, People in a manic episode will engage in risky behavior a lot of the times. This could be a spending spree, just spending all their money with no regard to anything. They might give away all their possessions. Um, they can engage in reckless driving, and they could make bad investments, and they could engage in sexual promiscuity. And you can see why this would be detrimental to the client. It can cause financial hardship. Uh, they could hurt someone in an auto accident. They drive crazy. And sexual promiscuity could affect their personal relationships. All right, now we're going to talk about the risk factors associated with bipolar disorder and the manic episodes. Suicide. Um, Bipolar disorder has the highest rate of suicide among all the major psychological disorders, and that's from a journal I found, Journal of Affective Disorders. Uh, Client with bipolar disorder, it's 15% more likely to commit suicide than the general population, and it may account for 1/4 of all suicides, and that's from the DSM-5. Um, that's kind of different than the video I seen that said 60%. So I'll have to rewatch that and see where they got that number, because I'm more inclined to believe the DSM-5. Environmental factors. It's more common in higher income individuals, and it's bipolar disorder is more common with people who aren't married. That could be someone that's divorced, widowed, or just never been married. And I'd like to know why, but the reasons for these facts are unclear. I got that from the DSM-5. There's probably a genetic component to bipolar disorder, because there's a tenfold increase in the risk among adult relatives, of those with bipolar 1 and bipolar 2 disorders. And it's kind of closely related to schizophrenia. Schizophrenia and bipolar disorder, they likely share a genetic origin. Here's the methods for diagnosing bipolar disorder. You assess the client's symptoms in a structured interview, or referring to the DSM-5. And you just kind of look to see if they're displaying the symptoms that are listed out in the DSM-5. You could have a structured clinical interview. You could do it like a questionnaire schedule for affective disorders and schizophrenia. You could give them a general behavior inventory. That's like a little assessment thing that they fill out, or a mood disorder questionnaire. And I got this from an article in the Journal of Clinical Psychology, Science and Practice. It's called Assessment Tools for Adult Bipolar Disorder. Okay, now this is interesting. I couldn't find a lot on this. Cultural and ethical considerations when treating someone with in diagnosing bipolar disorder. The DSM-5, they really didn't have a lot of information on cultural considerations, but I made an observation that it can conflict with religion. Like, for example, if a client says they have a special relationship with Jesus Christ, well, you would think I would go back to the grandiosity, having a special relationship with a celebrity, but it's actually just an aspect of the Christian religion. I imagine it would be the same with the Muslim religion. And I mean, Christianity isn't the only religion that could that you need to consider when diagnosing bipolar disorder. Like Native Americans, they uh, they respect what they call the vision, having a vision, which uh, culturally incompetent counselor may consider be a delusion of grandiosity. Now, I mean, sure, someone can mention Jesus or Muhammad or their personal deity and be having a delusion or of grandiosity. Like, for example, if they say they're Jesus's assassin, or let's say they say, um, yeah, Jesus is coming over Thursday night and we're going to go bowling. You just got to kind of listen to what they're saying and consider the religious aspect of what they're saying and also the psychological aspect of what they're saying. Some evidence-based treatment. What works for treating bipolar disorder? Medication. Medication coupled with counseling. If you just go with just medication, their disorder could get them to think that they don't need their medication and they could stop taking it and have a relapse. I mean, for the most part, bipolar disorder is a lifelong condition. So prescription medications be taken with counseling. And in extreme cases, they say electroconvulsive therapy is an effective treatment. Okay, here's kind of what I just said. Prescription medication should be coupled with counseling because the illness is likely to recur. Some clients may simply stop taking medication. The medication stabilizes the mood, the depressive or the manic symptoms, and it prevents relapse and decreases the suicide risk. And I got that from a textbook, DSM-5 connection. What type of counseling to use? What discipline? I mean, there's lots of them that could help. Psychoeducation does help the client better understand their condition and understanding what's happening to them. Should help them deal with it better. Cognitive therapy, it helps clients understand the aspect of the manic and depressive episodes. And counseling will also, it'll help the client develop better coping skills. And these are my references. I had to make 2 slides of them because I think I used 7 total. And that's it.